All right, I want to welcome everybody to our quarterly Doc Talk. This is going to be a great Doc Talk. Our speaker will be Dr. Kyle McGee, and I work with Dr. McGee, and I have ever since I've been here at CenterWell. My name is Chris Ann Dykes, and I have the privilege of serving as the senior physician recruiter for CenterWell Senior Primary Care Clinics in the state of Mississippi and the state of Louisiana. So the Mississippi and Louisiana is considered a market, and we have a market chief medical officer, and that is Dr. Kyle McGee. So this is a quarterly doc talk. We do switch off between different markets, and we have some amazing leaders when it comes to explaining value-based care. So I want to introduce Dr. Kyle McGee. He is CMO, like I said, for Louisiana, Mississippi. He's board certified as a clinician in internal medicine and pediatrics. And Dr. McGee, I'm going to let you finish all of your other background information and your accomplishments.
So thank you so much for that kind introduction. I'm kind of a guy who likes a lot of humor, so kind of breaks the ice, right, when we're doing stuff like this. So to break the ice, I will tell you that Chris Ann's name is Chris Ann, but it's also Peggy. That's the way it's kind of an inside joke. It's listed as that whenever I look at email. So we kind of have that kind of jovial thing that goes back and forth. So all in good nature. The other piece of this is I'm going to try to keep myself still as much as I can and try not to use my hands, which drive media people crazy, right? When I do that, because you're supposed to be absolutely still and not use your hands as much. So my folks who did media training would probably be, upset with me right now, but it's just kind of in my nature is who I am. So I apologize in advance for that as well. So a little bit about me. So I am a clinician, hard to believe for me to sit here and say that, who started practicing after I finished residency in 1995, went to a rural area and was a frontline clinician. So practicing traditional fee-for-service medicine, seeing both internal medicine patients and pediatrics. Obviously, I no longer do pediatrics, right? I'm in a senior focused value-based care entity in primary care. And so that part has, I've kind of put to the wayside. Uh, Spent about 20 years doing that. Actually 18, where I was a frontline and really did the whole gamut at that time, right? I was the person who, got up, rounded all my patients, went to clinics, all patients, did call, did nursing home rounds. So all the things that we did kind of as traditionalists in that time. And then I went to 2013, and I think a lot of that was because of sheer burnout, right? I could deliver the numbers when it came to a fee for service initiative or RVUs or whatever that is, right? And so thought that, hey, this is not as satisfying, it seems, because I kind of feel rushed and a lot of this is on me. So I think that, I can have a bigger impact. Maybe going to administration, did a hospital administration for about 3 years, and 16 was my first taste of value-based care. An organization reached out and asked me if I wanted to be CMO. And I thought, okay, well, been a frontline clinician, ran a hospital. And so I kind of got this right as we kind of went through it. And it spoke to my heart. And I think you'll find why it spoke to my heart as we go further through this. When I went into it, realized that everything that I had learned while I was a really good clinician, there was some things that were way different with value-based care. It spoke to me, but there was a big uptake in my learning. And so even as the CMO, the organization I had to be humble and get the folks that had done this frontline for a while to kind of teach me how to do value-based care. And I'm always grateful to those folks. And so I've done that with two different value-based care entities. I've been here at Humana at CenterWell for 3 years. I'm grateful. Didn't think that, I thought my last stop would be my last stop, and it ended up not being because I think that this organization had a vision that spoke to me as a provider and have been here ever since and been really, really happy with that decision.
You have such great background for this talk, and I love listening to Dr. McGee, and you're going to find out why right now because he has so much knowledge on this. So, Dr. McGee, can you elaborate on what value-based care entails and how it differs fundamentally from the traditional fee-for-service model? Because you kind of spoke to that in your background.
Yeah, no, I think that's very true, right? I spoke a little bit about that, but a little bit more in depth is that for me, it's kind of like, well, let's go to the first principle. I think when I came out in 1995, right, I really, you're trained that you're going to really change people's lives. You're going to help people. You're going to have all this time. You're going to solve the problems. You're going to make people better. And one of my experiences was, and some people could say, well, you stayed there for 18 years, right? Maybe I'm a slow learner, right, around that. But with that being said, I quickly got tapped on the head by like a CFO who was like, that's great, Doc, but can you see 24, 25 patients a day because you need to meet that to make your salary? Right. And okay, and I can see volume, right? But there was a lot of instances where I'm in a rural area, people who were very complex, right? There was a lot more going on here than just simply that happened within my walls when I was touching people. And, really felt like a lot of times I did not have the
Insurance
time that I needed to really
on like your
sit down and
say
go into depth around some of these
just
things,
writing for study
including
all the
when
time.
people had
Just saying.
multiple complex conditions because it's like, all right, I got to speed this up because there's another patient waiting, right? So I felt like that I was actually, not giving people time. And I think that the other piece is I was catching people a lot of times, we're taught a lot of prevention in medicine, right? That, hey, if we catch disease states early, then people have a better outcome, right? And sometimes we can reverse or cure things if it's caught early. And that was one of the things that I had as kind of a goal and mindset when I came out, but realized while I had maybe a little bit of time to do, that wasn't really the value in this, right? For the organization I was working for. The value was how many patients I could see, how many times I could send them to a specialist, and in a rural practice, I wanted to see my patients that were sick. And I would make time, and sometimes at my own detriment, working long hours and stuff because of the fact that, I felt a responsibility for them. The honesty is that the whole alignment was more toward, well, you can feed my specialist, right? And you can be a conduit to getting people in the hospital. So I started to realize that, and it's used very cliche now, but I think I did realize at that time I'm on a treadmill, right? I feel like I'm kind of running on a treadmill constantly and never getting anywhere. And then really started realizing that uh, I'm doing a acute care. It's very transactional, and I don't feel like I'm doing a lot of prevention. So when we flip the switch and go value-based care, as I told you, I walked in 16, my first taste of this, and kind of like a lot of physicians, I thought, how can this be sustainable, right? If I'm seeing fewer patients, how? How can this be sustainable? And realize that, by doing this and screening for you know, things that we can prevent, right? I mean, you think about things like low dose CTs that we do as part of kind of some of our EDAPS measures, and we do echoes for stage B heart failure, which is interesting, was a value-based concept in 2016 that people were starting to latch on to. Now there's actually articles in the cardiology journals written around this, that's where the wall of the heart starts to change, right? You get left ventricular hypertrophy, you get a geometric change in it. That's the precursor. That's asymptomatic. The next stage is C, where people really start to become symptomatic, right? And I was doing some of those things in fee for service when I was trying to explain to people that, hey, this is a pump. Big muscle in your pump doesn't work. And sometimes they would take their medicine. So it's like they got LVH on an EKG. I'm going to do an echo and show them this. Well, that's actually what value-based care is doing. You're screening people for things like that, going, if I control your blood pressure, we get your handle on your diabetes, we control, your cholesterol, you exercise, you do all of these sorts of things, and all, we can prevent you from moving into stage C heart failure. And now we know that if you do that, people actually live longer, right? There's actually proof out there now for that. So the ability to take that additional time and do things like that with smaller patient panels and spend more time. And then the other piece of this is that one of the things I found is how do I really build, and it became frustrating to me, is how do I build in trust and influence over people? Well, kind of you go wake up and look in the mirror and fee for service, and it's like, hey, guy, that's on you because you're spending very little time and you're rushing people out the door because you are on this treadmill to make your metrics and make RVUs and stuff. Where here I can really sit, get to know people, and sometimes get to know that there's some things that are really important to them. They've had a loss in their life or something. We can talk about those things. And then we get to things like their hypertension and diabetes. And I don't think that the traditional fee-for-service model is geared toward that, nor do they really want that, right? And so what I say when I say there's value-based care, there's value on both sides of the equation. There's value for entities like us, lower patient panels, the way that we are paid to basically control the total cost of care by getting in front of disease states or managing a chronic disease to stability gives years to people's life. If it gives years to people's lives, then you don't get all the downstream effects. You don't get increased ER utilization, hospitalization, in and out of rehabs, LTACs, and everything else that you see a lot of times in traditional fee-for-service. That may be value to the organization, but from my side of the equation, I think that's value to a patient, right? Because that we take care of each day because we're extending their life and they're not in a hospital setting. They're actually out there playing with their grandkids, or they're going fishing, or they're like me. They have a crazy passion for LSU football and they're going to LSU football games, right? And eating, Cajun food or whatever. So I think that's some of the value. And I think we'll touch a little bit more on that, and the picture will start to come together as we kind of peel back the layers of the onion here. So, Chrisanne?
Okay. In your experience, how has VBC positively impacted patient outcomes and overall healthcare delivery at CenterWell?
Yeah, so I think that a little bit of that was touched on right there,
Hmm.
right? How do we impact patient outcomes? So I think we impact patient outcomes positively and give them something that I think we all find more value to. I've got a milestone birthday coming up, and I have a 91-year-old mother, and all I can say is I hope I have her genes and I make it to that, because there's a lot of things that I want to do, right? So I love the fact that we actually are doing these things and adding true value to people's lives, right? Because I think if you can give them that value, right, it is incredible. That's an incredible gift that we can give patients in our model of care. So I think that really is the value in that. And we see that every day, right? I think that statistically, what we see too, from a statistical standpoint, because you can talk about it qualitative or quantitative. So if you want to go more on the quantitative side, when you start to see that we have 30%, in some instances, greater than 30% reduction in ED utilization, we have, 10 to 15% reduction in our admits per thousand and high quality scores. So I think that really you can speak to the all around value, not just for patients, but for healthcare in general.
Could you share specific examples where VBCs led to enhanced patient satisfaction and improved clinical results?
Yeah, so as far as enhanced patient satisfaction, improved clinical results, I think there's a couple of factors there. Like one of the things that we follow are NPS scores, right? We Net Promoter Scores. And so we pride ourselves on having incredibly high, probably as high as anybody, and I would wager to say probably higher than most in a healthcare space, and to a degree, probably in the value-based care setting, really high NPS scores, right? So, and we really have a team approach. So they're not only looking at I always tell my team this is a team sport because it's like front of the house. It's how a patient's greeted when they come through the door. It's when they get to the back in their room. It's when the provider is in the room, and then as they exit. So we have really, really, great NPS scores. I think that from some of the other aspects, right? There's so many times that we have patients coming back to you. Like I experienced the other day, I was in a clinic and basically had a patient tell a provider in front of me, "You saved my life." Right? I don't think there's any bigger testimony or praise that you can get to that. Right? Because they felt like they were getting put off in another healthcare organization and things weren't getting addressed, and they were kind of the one problem today and that's it, and you come back for the other things and all. And so I think that those things really speak to that satisfaction amongst patients. And then I think it also leads to provider satisfaction, right? I think that at the end of the day, I think we all were trained, and that's what we came out to do this job was like, yes, we want to have a great income and everything. Absolutely, I do too. But I think at the end of the day, too, there's also a piece of that the knowing that you have impacted somebody's life positively. And I could go on with some of our resources that we have and how, outside of bricks and mortar, we've had found patients that have had issues with housing or food insecurity, and we were able to solve for those things. And actually, they became more compliant with their regimen of treatment and things of that nature. So, and we'll probably even talk about that a little bit more as we keep going forth in our conversation.
We are. And now we're going to go on to work-life balance at CenterWell because that is important to physicians. In fact, I address that every time I screen a physician. We're talking about the hours. So, which strategies or policies does CenterWell implement to support a healthy work-life balance for physicians and our APPs, which is so important? I think probably COVID didn't help. Everybody has a COVID story when I'm screening them.
Yeah, I think everybody does, with that, and it causes a lot of physician provider burnout, clinician burnout, support staff burnout. I mean, we can go ad nauseum into that, right, with COVID. And my hope is that we don't see that happen ever again. So, or at least not for a very long time if it does ever have to happen again. But with that being said, first, I will speak really probably to my role as a CMO, right? And I have seen patients in this model of care. So I don't want anybody to think that, I'm just kind of an administrative guy while the majority of my work now is clinical admin. I've actually seen patients in this model of care. And, one of the things that we do, and I think it's different because I have been, fortunate enough to work in a couple of value-based care entities. I think we have senior leadership above us that listens to, right? I think we are truly able to be physician advocates from our roles. So, in things that impact work-life balance, right? For instance, we all know that being able to close your notes and leave the clinic at the end of the day and not take that work home with you, because I call those hidden hours, right? Because nobody, if you're just, and look, I'm a clinician first with a business degree, and I always say that. Chrisanne probably gets tired of hearing me say that. So I always think about it from that perspective. Nobody looks at the hidden hours, right? That you do offsite, that you do at night, sitting at a countertop, closing notes for a couple hours when you're taking time away from your family or whatever that may be, right? And so I think we've been very diligent to make sure that, we're doing things to support our providers like that. One of the things that we recently brought on was a bridge technology, which is AI, right? To be able to actually record with permission from the patient that tees your note up, very precise, right? And you can basically do that note quickly. So you're not having to basically go home and take those things home at night. Lower patient panels also. So there's that piece of it. So when you are basically really doing the whole thing with, the 10 or 12 patients a day and you have more time, you also have more time to not only take care of your patients, but more time to actually do some of those things like documentation and things as well, right? So I think there's that. I think the other piece of it is that we've really done a nice job. We have some, we had some what I thought was some great PTO, but with listening and thinking about, how some of the other players in the market, and this is from, value-based care entities to maybe some of the bigger integrated health systems, that they had some additional, maybe PTO offerings. We actually lobbied and were able to get additional PTO for our providers. So I think those sorts of things where you actually can leave work, right, and truly leave work. When I mean leave work, you can leave work when you're supposed to go home at 5 o'clock and leave it, right? And you can go have dinner with, right now, having a grown daughter, it's my wife who also works. I like to have dinner and I don't have to say, I got 20 minutes to spend with you and now I got to go do notes or whatever, right? So, or you can go to a ball game or you can go do whatever it is that you like to do with your downtime, woodworking or whatever that may be, right? So I think it really gives you the ability to leave work at work, if that makes sense.
That does. And I know some NPs that have to do all their notes on their days off.
Know
And
some physicians that I've talked to over the years and
yeah,
recently, and who have, and had one recently joined us that actually, and was with an organization for, gosh, almost 20 years. Like, he was trying to, great guy. Actually, I'm in the center that he's in today. And we had that conversation, and he struggled because, he loved his staff and he loved everything else, but then making a jump after a 20-year career is, and I get it, it's really one of those things that you, as the person who's in the midst of it, have to make that decision and all. But yeah, I mean, that was one of the things he was doing. He's like, he admittedly said, I'm going home and taking stuff home, and 2 or 3 hours a night I'm doing work at home. To your point. Yep.
that's right. And that was a clinician that I was talking to, and I said, I would like more time in the clinic, but Dr. McGee won't let me go to our clinics, but that's okay. It's the only thing I'm too young to go to. But yeah, I
Oh,
can't
wait a
wait till he
second.
can.
Okay, I'm glad you qualified that statement, because there for a minute it sounded like I was like, I invite you to
No,
come to the clinics all the time. You're talking about it as an actual patient.
no, we,
Okay,
we
all
were at
right,
a
I
conference
got
and
it.
I got to listen to Dr.
I
McGee
got it.
explain medications, how they interact, just everything your PCP does not have time to do. I said, can I just go? I wasn't here long. Can I just go to one of our clinics? I work here. He said, no. That was it.
Well, I think it does. I mean, and this is kind of what I like when you do these things. I think the spontaneity of being able to do those sorts of things. I also think that the providers are the center with the patients, the center of care, right? And we have all these great resources rotating around them, and we call our providers kind of the quarterback of the team, right? To Chris Ann's point. So, you can. I think it's good care. You can call it. Micromanaging, being nosy or whatever. But I'm very protective of my patients as an internist, and I want to know what other people are doing with my patients. And I always had that relationship when I was out. That was one of my demands, right, from my cardiologist. They knew, like, if I want to get providers from McGee, I got to make sure I follow up with him, right? If I want to get consults, excuse me, from McGee, I got to make sure I follow up with him. So I think that that's one of the things, and we have mutual respect for each other, right? And so we make sure that care is coordinated, that, because sometimes, to your point, you're talking about medications and adverse reactions, people can get placed on the same medications or same classes, and nobody, one person's doing this and one person's doing that, and then it gets to be, again, I told someone today, as you spend more time around me, I have a lot of bad analogies. Probably there are really too many cooks and not a single chef, right? And so that really, and I think we've all seen it, whether we kind of want to, you know, say it out in the open or not. We've seen what that leads to with patients sometimes, right? And so that, if you don't know what Dr. X over here, whether he's a specialist, another primary care provider, is doing with the patient that you're seeing the bulk of the time, and you don't have line of sight to those sorts of things, then you may do something, give something that could have some sort of adverse effect and lead to, consequences that are undesired, that you didn't intend or want. And so one of the things we want to do is make sure that we are coordinating all of that care so that we don't have instances like that either. So that was a great point that you brought up that I kind of failed to mention too, Chris. And so I really appreciate
No, it's
that.
okay.
So yeah.
Um, so back to flexibility, working
Mhm.
for CenterWell, can you discuss any flexible scheduling or wellness programs that are available to the staff?
Yeah, so there are a couple of great points. Flexibility, wellness programs, those are real, and they should be top of mind, hot topics right now, I think, for, all healthcare workers, particularly clinicians. We are a de novo market, and so de novo means just what it does in Latin, right? We're new. And so we are a series of clinics in CenterWell that don't have the kind of years of tenure. So you may see Conviva, and Conviva and CenterWell are the same entity. They're just more mature clinics. So with that being said, we are in my market, and some of the other markets are more mature. So they're on a probably further down the road in that we're doing something, and it seems to be going really well right now. So that is something that we may very well, as we continue to see how it works, uh, we may very well continue to kind of cascade throughout our market. One of the other things is there's another that we are really probably going to do in a couple of the other clinics is there's kind of this 980 concept where basically providers work, if it's 2 weeks is considered 10 days and there's 80 hours, we're actually doing the thing where every single or every 2 weeks they get a day off, a full day off from clinic. Because look, I understand the same as you do. I mean, my job now is, Monday through Friday. It had been in the past and all, but it's really hard to go to the dentist who is not open on, basically the weekend. If you don't have a day off, there are other things you may need to go see your accountant. I mean, I think, oh gosh, tax season is coming up. That just popped into my head. Your accountant may not be open on a Saturday and you need a day that you need to go things like that, or, you need to go do something with one of your kids if you're still have younger children that are not driving and all. So we know that those are things that are important, and we're really solving for those types of problems, right? As we continue to move forward here. So there's a lot of that. We also are looking a lot into it, and there's been a series done on physician well-being. So we're looking at bringing on some additional resources around that. So there is a big program going on. Actually, there was a meeting today. So I think that there's a lot to come on the whole physician or clinician well-being aspect that we really are. Uh, we're pretty, I'd say, pretty adamant, and that probably is, not a strong enough word about doing and impacting, because we do provider engagement surveys, right? And some of the things, and we want to be seen as, because most of the time when you do surveys, I think people say, well, that's great, I did a survey, but nothing ever happens with it, right? So when these things get surfaced for us on these provider engagement surveys, we get tasked as CMOs from our more senior leadership. Hey, how do we solve for things like this, right? And so there's a lot of solutioning going on around things like that, and putting programs and stuff into place. So
Let's transition into unique patient needs. So, what unique healthcare needs have you encountered within the communities served by CenterWell?
wow. So that's a lot to unpack in that question, right? So
I
first of
think you can
all,
do it.
yeah, I know you have faith in me, right? So I think first of all, we have to think about that, or I have to think about it from perspective of where we go. And this is, you heard me, and I want to answer the elephant in the room, which is really not the elephant in the room, but people a lot of times want to go, well, why did you go to, you were here at this value-based care, here at this value-based care, and then you're at this one, right? So I think with that is that we are really, really intentional about, this organization is intentional about where we're going with our model of care. So obviously senior focused, right? So we're payer agnostic. We take all payers. I mean, some of you I know have looked up that, well, they're like a subsidiary arm of Humana, and we are, okay, but we're also payer agnostic. They're just another kind of payer partner that we have from that perspective, right? But I do think, with that being said, I think the PCO, as we call it, is a primary care organization, which is the clinical arm, right? The care delivery side of the house. And along with Humana and some of the data that they provide with us, we're able to go set our centers down in areas where people need us the most, right? And so for me, if you go back to what I said initially, being in rural medicine, 60% of the population in Louisiana's weird, right? They call them parishes. We're the only state in the union that actually calls it parishes. So in the parish I was in, 60% of people live below the poverty limit, right? And so that's an underserved area. We also are there. We intentionally look at seniors, how many seniors are there in underserved areas, incomes, right? That people typically don't want to take on in big health systems, and not on a basis with regularity. So in all honesty, they really become marginalized. And so we want them, right? Because we think our services, our wraparound services, and one of the things that's very cliche that I use when I talk to folks is, and actually I interviewed a physician uh, last week who actually said it's almost like concierge medicine. I laughed and I said, you stole that one from me because I said it's concierge medicine without the fees, right? So we're able really to knock down the barriers to people being taken care of. Uh, we can provide if they need to get here to see us, we can get them transportation. We can provide transportation. There's a lot more, and I think all of you guys probably on this call that know this really well is there's a lot of stuff that goes on, and it took me a little. Again, I told you guys sometimes I wasn't as quick as people think I am. It took me a while probably to understand this in my early part of my career. There's a lot that happens beyond the four walls that of medicine, right? Inside of our corners, inside of our brick and mortar. We can come up with, and I think that's where the challenge is, right? That I think the majority of all clinicians want to give great, care, great plans of care to their patients. I think we own that. But what happens when they walk out the doors? And what I tell people is you can set up the best plan of care. And I saw this in rural medicine all the time, which is to why this speaks to me, right? But if people have to make choices every day around if I buy this medication, then I can't eat, right? Or if this person doesn't have, a good housing situation, how can we expect them to take care of themselves, right? And then even with our seniors, you start to think about most of these folks are not fortunate enough that they have others in the family they can depend upon, whether that's their spouse has died, maybe their kids are grown and gone. And so they have not only have transportation issues, they have loneliness, which leads to depression, which if you don't solve for that, then there really becomes an issue. There really becomes an issue of, you know, if you're in a dark place, can you really take care of yourself, right? And so I think that if you don't solve for those, and what I tell my providers all the time is again, I'm the doctor of bad analogies. This healthcare thing is a three-legged stool. So we can put one leg on it, which is that great care we give them inside the clinic and that great plan of care. But if you can't solve for those other two things, when I ask my providers, what would be the chances you're going to go sit on that stool? All of them go no. I said, all right, well, so if you don't solve for, basically the social determinants, or you solve for social determinants and you got a plan of care, that's a two-leg stool. Well, I may sit on it, but I really wouldn't trust it. I was like, okay, fair enough. But what if I told you I solve for all three of those things, right? I solve for basically, any kind of behavioral health needs or issues. I solve for SDOHs and I give them a great plan of care. Well, I would sit on that stool every day of the week. And so maybe bad analogy, but that's what happens. And I think that that's really, kind of, I know that's what we do on a daily basis, right? So.
That's a good lead into engagement and community activities because you've kind of touched on something we do in the clinics or, uh, our activity center kind of helps that. But, how are you involved in community initiatives throughout the year and what are, describe some of the activities that we do to help our seniors?
Yeah. So again, a multifaceted question, right? So when we start talking about community involvement, I think all of us have a passion and we get involved with, locally, like, the Council on Aging, senior centers and stuff. We get involved with those kind of right off the bat. We try to find those, and we do things like, we have a passion for giving back to a community we're in. We are kind of somebody who is basically when you go into a residential area, I think is the best way to describe it, right? You're a newcomer. So we're a newcomer in the space. People have been there forever. And so being a newcomer, we also want to be great neighbors and we want to give back. And so we'll offer, we'll say, hey, look, we're happy to come do, our clinicians, to do talks around things like, let's say, brain health, heart healthy eating, basically doing diabetes and how to eat appropriately on a fixed income. So, and we'll even do basically talks and different things for them around a lot of these things. We also, reach out to people and say, hey, look, we've got, like, let's take Alzheimer's. We've joined their Alzheimer's walks. We're involved with the walks for the American Heart Association as well. Our providers enjoy those. Our entire staff enjoy those, and it becomes competitive where they actually, get people to sponsor them, right, for their walk. So they raise money and stuff for those things, and the Alzheimer's walks are the same. So there's a lot of community involvement from that aspect. I think the other piece of it around our community are our activity centers, right? Each one of these centers has about 1,000 square foot activity center in it. And we do, meaning CenterWell does a lot of things in those activity centers, but we also offer them up to other people. Like, for instance, one of the things I'm trying to really get off the ground, I kind of have a passion, and I think kind of as, I move forward into my career and start to take on, like I said, years down the road, kind of a semi-retirement role or whatever, then I want to, really continue to support the work that the Alzheimer's Association is doing. So there's a little bit of probably selfishness with me in that, but at any rate, I think it's a really great cause. And so we've reached out to them and said, hey, look, if we need to keep our activity center open after hours for you to give, to do an Alzheimer's support group, right, for the caregivers, we'll do those sorts of things. Also, if you would come and do education for, basically our own patients, but we'll invite community people. They don't have to be CenterWell patients to give, talks and things inside of our centers. And so that's another way for community involvement and really, being involved in the community. The other piece, as far as the activity center, is, a lot of you may have had the experience where you've worked in assisted livings or nursing homes. I was blessed enough that I actually had nursing home patients. There is nothing that senior folks like better than bingo, right? And so we actually will do bingo in our center, in our activity center. And we have patients that come to that, as well as we have patients who we have people who come to it that are not our patients or members, right? And so it's like, yeah, come on. And so I think not only are we solving for some of these things I talked about earlier about the isolation, right? The social isolation, got a little tongue tied there, that these seniors experience. I think that we're really solving for that by getting them out of the house, getting them involved in something like bingo in a cool story. I mean, you talk about some of these things. I know we talked about some of the impacts and things we've seen. I've seen people come in, it's real story, right? Come into the centers, not know each other, come play bingo. Neither one has a spouse. And within a few months, they're the best of friends, right? And if one can drive, they'll go pick the other one up. And then so doggone, you just solved the whole, basically probably a mild form of depression, I would wager to say, by just getting them in contact with something, getting them out of the house and getting them doing things. So I think that, that's one of the great things that we have about our activity center. But I also think, just spoke to a lot of the things that we do to be involved in the community too, which is one of the things I love about this organization as well.
I think you answered my next question already. So, how does the community involvement enhance your role as a healthcare provider? You might have touched on that as well.
Yeah, I think that that really speaks to how, we touch the community, right? And I think touching the community is multifaceted. Like, I encourage our providers to go do, because I want them to be the face of the clinics. But about probably 6 months ago, I went to basically, and it was great. I don't know if you guys have ever been to there was a senior focused exercise class at one of the athletic facilities or whatever here in the area that I'm in. And when I tell you, it's like, Chris Ann's talking about, I told her she couldn't join. I was like, can I join you guys? This is really cool. But with that being said, I did a talk on brain health. And I mean, how many of us over time have had people who are worried, and maybe they did or they didn't ask their provider, right, their clinician, about, is this dementia? But went through brain health basically with, hey, this is the type of things that are just natural, because we all know there's some cognitive decline that we naturally experience with aging. There are also some things you can do to help that, as well. There's some modifiable risk factors and things that you can do that may help that to a degree. But the flip side of it is that, hey, these are some of the, basically the red flags for dementia. And out of that you get, and I actually got approached by a someone there who was a spouse, right, who came up to me and talked and said, you know what, this was really good. I've been really concerned. I am really concerned about my husband. What would you recommend I do? I was like, you need to go to a visit with your primary care provider and you need to be there because it's a difficult conversation, right? But you really need to bring these things up because there are things, even with dementia, that there are modifiable risk we can get on. The sooner you start medication, the better, right? So I think that speaks to a little bit to the impact that you have when you're involved in community activities. So that's kind of a real-time example, I would think.
It's time for question and answer. Are you ready?
Wow, that went
I
quickly.
know that went very quick.
Yeah.
I do want to
Don't.
I want to give a
Yeah.
plug for the new one of the centers has. It looks so neat. They play bingo and they show all these fresh fruits and vegetables. Such a neat setup that they have. And they do take that
Well,
bingo seriously.
it's competitive, man.
Yeah.
I used to not think that, but I mean, they would be paying like for $1 when I was around in a nursing home, and it can get really competitive. It was kind of fun at times, a bad way, but it does get really competitive. It's fun to see.
Okay, so this question is from Dr. Aguilar, and he said, "What would be a patient panel for docs like us, internal medicine in suburban city, and how does that translate to average visits per year?"
So there is going to be our mantra, right, or kind of our set point for physician patient panel is 500, right, for a physician. So, and then usually, and I think most healthcare systems, integrated healthcare delivery, probably even people who are maybe still in private practice, use APPs, nurse practitioners, and things of that nature. So 250 typically for the APP. So that's really the patient panel. The average, so daily visits, we really want the sweet spot is about 12, right? A day. Now, I have a couple of centers up in Bossier that are 3 going on 4 years of maturity, North Louisiana, right, that have large numbers of patients. And they probably are hitting on average probably 10 to 11 visits a day. And that typically is room for, hospital follow-ups, making sure that we have that, making sure that we have one or two acute visits in there. So that if people, that's the other thing, we're about access, right? So we don't want the patient to call and say, hey, I'm not feeling well. I have fever. I have a cough and everything. We say, hey, can you come in at 3 o'clock? We have a visit and try to get them in. So typically, so 20, if you do the whole weekly or whatever, then you could get to the number a year, but the panel size is actually 500 and the number of visits per day is really at maturity about 12.
And he has another question. Good. In the fee-for-service model, we would see the high-risk patient more often. How do you balance HR visits with lower-risk patients while trying to meet metrics?
Wow, that's a really great question. That sounds like somebody who's got a little bit of insight into this. I like that one a lot. So we also, so you heard me say, and I'm not going to, say anything to that. And I think each individual value-based care entity has some of their own things that they have, right, and that they do and follow. One of the things here is we believe in giving our clinicians autonomy. So, which I think speaks to, was that Dr. Aguilar's question too? Or okay.
Yes, sir.
So, which speaks to, I think, an autonomy piece of that too. It speaks to two pieces, a little bit of autonomy and then a little bit of how do you manage, right, the day to day. With that, we would hope that you would focus in on the people with the highest disease burden, the high risk patients, and things of that nature. So your visit frequency should probably be more, right? With that being said, I'll give you a simple example of an area I'm familiar with. So Metairie is a very suburban area in New Orleans, and it's very so everybody thinks New Orleans is a big city. It's literally if you go into Orleans Parish versus Jefferson, where actually New Orleans is versus Metairie, it's like 3.5 miles. So from a distance perspective, if you look, it's a higher need area in the mid city, right? Because you have income levels are lower and everything, higher income level in Metairie. So if you get into this narrative of telling people, oh, I need to see you, X number of times a year, let's say you tell that same patient who is lower risk, I need to see you 6 times as well. And you're telling the high risk patient, there's a couple of pieces. Number one is that some of the pushback that I've experienced is you have a 70-year-old who is probably healthier than me, who is, he or she is probably 10 to 15 years my senior, and they're playing tennis and doing all these things and traveling, and they're like, I like you, but I don't want to come see you that often. I got things I want to do. So, and they maybe have mild hypertension. You really don't want to see them and it doesn't make sense other than maybe, once a year for their hypertension. If you're going to do an annual wellness or preventative visit, probably twice a year. So we say, hey, look, these are the patients with all our basically all our data in the background, and these are falling out as to your point as your high risk patients. They probably need more touches, which is more visits. And then these are patients that may not, but here's the metrics I want you to achieve from basically an ER VPT, right, and an APT or admissions per thousand perspective. How you achieve those, you probably are better at that than I am. You probably can figure those sorts of things out, right? Now, I'm going to give you the education because there again, I said, it's a different model, and there are people who probably doesn't have the same thing that you basically. Sorry, I lost my track. I saw something pop up on my screen. But, I'm going to also give you the ability to actually manage those patients as well. But I'm also going to give you the education. That was what it was, to be able to be armed with the ability to do that. So I think that, our focus, great question, but our focus is that to where we have more frequent visits if they're higher need, fewer visits if they're lower need. What you do, and I tell providers this all the time, I can give you great basically population health data. I can give you all kinds of analytics, but every study you go look at tells you that even the best, Johns Hopkins has done a bunch of this stuff and everything. They tell you that the one thing they can't solve for is physician gut and intuition. So if you think a patient's about to pop off as a high risk patient and you want to start seeing them, then with that intuition, I would tell you follow your intuition and do it, right? So long answer, but I hope it answered the question.
And another one from Dr. Aguilar, what may we see from CMS and the money reduction efforts from the new administration as it impacts VBC and documentation? And Dr.
Man,
Aguilar, if you want to pop in here, you can talk.
that is a great, wow, man, this is really, really
Yeah.
good stuff. So I think that
Well,
Dr.
I
Aguilar,
can't say I'm enjoying your conversation because I also practice in rural and suburban in different times, and they are different populations. But certainly, understanding how CenterWell facilitates time to be able to make an impact to lower to improve clinical outcomes. But certainly, are you seeing from as a CMO? Are you hearing what CMS might be doing or what they might be looking at in terms of adjusting the costs, because there is a lot of waste and abuse in the system, and certainly
right.
value-based care is where it should be going. So what are you hearing coming down the pipe?
So there's a couple pieces, right? And so I'm going to say something that you may smile when I say this. V28, a lot of providers probably won't know that, right? And I expect them to know that. So I think they did that with V28, right? And I'm going to be one of those. This is a Kyle McGee thought, right? I don't think it was a bad thing, right? Because I think you've got to have a balance. You've got to have a balance of where you're identifying chronic conditions, you're developing a plan of care, but also, I think my personal concern is not to go making sure that we were not really more aligned with revenue. And I think CMS to some degree addressed that with V28, right? So what I would tell you is that and you may shudder a little bit. I'm kind of excited because when this started coming down and we had insight to it, almost, I guess, a year and a half, 2 years ago now with it. I mean, I remember kind of saying to our national CMO, and he smiled and chuckled, and I said, game on, right? Because now we got to do what we do best as providers, clinically integrated teams like our care integration team that's at wraparound support with all these social determinants. We've got to be focused on that because the bucket of money is smaller, right?
Yeah.
And so we got to get better at managing. And I think there's room for us to get better at managing this. What will happen would be conjecture on my part around, CMS and what they're doing. But I also think that the ability to take risk, right, which is what we do at the end of the day. CMS says, I'm giving you so much per member per month to take care of the patient, right? And then and the plans that comes from CMS. The plans send it down to us, and then kind of almost the plan is a third party administrator who's playing claims out of our bucket of money that we've got because we are at risk. I think having skin in the game is a good thing. Now, as far as the payment, who knows? I
Yeah.
think
So
that they may
yeah,
cut some
yeah,
more. I
yeah.
don't know.
It's too early to find out, but I thought maybe being ahead of the pyramid, you might have heard something by now. What about certainly the after hours care is always a concern, especially us as internists and people that didn't get their insulin filled at Saturday night. It's how did that happen? What does CenterWell do for the after hour cares, and do you provide visits at home for those high risk patients who want to decrease their admission rate or 30-day readmit rate?
So a couple of really, really good questions. So first about what do we do with patients at home that run out of medication on a Saturday? So we do have a provider only on telephone call, right? Or a clinician only on telephone call. So after hours, the clinic shut down and on a weekend or whatever, then there's a provider on call. We also are fortunate enough that we're large enough, like in my market, like in let's because I have two states, right? Let's talk about Louisiana, where we have a little bit more maturity, a little bit less in Mississippi. 14 centers in Louisiana, 4 in Mississippi currently. With that being said, we have a large group of providers where a call is really, they're on call 2 or 3 times a year around that. So that's one thing. I think we are also looking into things like at what point do you add something as a buffer in between there, maybe like a nurse triage line that, if you have an RN that probably could do some of those things,
Triage
right?
costs and
So,
then flag it up to a provider, right?
so I think we're looking into things like that. I think that which is a great point, we do have an entity in Georgia that I was fortunate enough to be part of for a little time. I was flexing to give some coverage in a home-based program in Georgia that we acquired, and we're kind of running a model there. And it's actually what you're talking about is actually to
A
go to the
home-based visit.
home, right?
Yeah.
To do home-based visits. I think that, one of the things with me as a CMO, and one of the things I like about this too, is ideas don't just get shot down, right? When I say, hey, I've got a provider, like I've provider in the far west said, look, and she's got a very decent patient panel in the clinic, but she's been there for a long time. She's like, man, I would love to do one day a week and go to assisted livings. And I was like, I tell you what, this year, if we want to pilot something like that, let's you and I get together, talk about how we pilot that. If you want to go to assisted living, if you get 8 or 10 patients in an assisted living, and you
Yeah.
can just go
Yeah.
spend a day there,
Yeah.
right?
Because they're
And
all
see
there. They're
and see
they're
patients
not
there.
right.
So I think we're trying to evolve this model. And I had this conversation with not necessarily somebody inside of CenterWell walls yesterday, but somebody else, that had kind of like-mindedness around some of the things that we're doing. I was like, this is the evolution. You heard me talk about what can we do outside of bricks and mortar, right? We have to get to, in my eyes, we have to get to a point where we solve and are able to deliver care in home, right?
Yep.
And so I think that's the next step. That's as we grow and expand. Those are things that are already kind of being thought about.
Yeah. That's the fourth leg of a stool.
Uh, Very good. I like that. I'm going to use that. I'm going to steal
No,
it from tell them
no,
Dr.
somebody
Aguilar
taught me
did
about
it.
the stool as analogy. So yeah.
Yeah, I'm going to steal that from you. So
No, no, no. What EHR platform does CenterWell use, or use different platforms in different areas?
ECW currently, and we are actually deploying Athena. So that's another piece of it. So
Deploying Athena. So you're switching over to Athena?
we're cutting over. We're going to cut over to Athena. We're leaving
Wow.
ECW. Yeah.
Wow, wow.
Yeah. And
Now they're
so,
both great platforms, but ECW is coming out with their new Sino, their AI. And
yeah.
even with that, you thought switching over was a better idea.
Yeah. We can have an offline cut and I'll tell you
Yeah, yeah,
why,
yeah.
because there's some APIs and stuff that ECW doesn't have that
Yep.
limits your exchange between,
Yep.
information
They
in and
they don't
information
talk to
out.
anybody. Nobody talks to them. Yeah,
There
they're
you
so
go.
hard. It's a
I
wall
said
of
it
China.
without you saying it.
Yeah,
So
yeah,
it
no, no, I know.
doesn't,
I know.
and the more you can get this in front of clinicians in real time, look, I said I was a hospital administrator and I used to, so I did paper, right, and went to
Yeah.
EHR,
Yeah, I
and
remember that.
I was about to say you may have had some of the same
Yeah, yeah,
experiences,
yeah.
right?
I practiced during the Civil War. I was in the 80s when I came out. So
Well, I was in the Revolutionary War, so at any rate, I got you beat. But at any
yeah,
rate,
Okay.
with
We
that
could,
being said, yeah,
yeah.
that's a
I do want to leave
great,
room for other people to ask questions, but I do
yeah,
want to thank you for
yeah.
the great presentation and your nice, diverse conversation, including the wellness centers and the providers' health and some of the other programs that you guys are bringing up. So thanks for your time.
Well, thank you for your time. I know you're busy and everything, and really appreciate you just being here for this. So,
Well,
absolutely.
Dr. McGee, we just have I think two
Yep.
more questions. One is,
All right.
how is desktop coverage handled when a provider is out on PTO?
Yeah, desktop coverage is kind of the simple answer is we're de novo, but we always start with two providers, right? So we start with a provider and nurse practitioner. And one of the things as kind of I now have AMDs underneath me, and I think this has been a good thing that they've cascaded as well, is okay, you can't basically both providers be out at the same time, right? So if you come up with a day, it's like, when I was in a private practice and all, it's like if you guys and making a call schedule, if you guys have to go out and arm wrestle, which I don't encourage because I don't
come
want
back
to
with the
get in the
list. Come back with the list. Yeah.
crosshairs of HR, but it's basically work it out and tell me who's going to be here. And then basically it's the same thing, right? It's like that person covers for anything that really is acute that's needed. If there would be a provider in a center, let's say that physician gets sick and the nurse practitioner's out, then we would flex some coverage to be able to cover that center so that, you're not coming back to anything that would be acute or urgent. Or now what I will tell you is because I think we all know that, right? You got to set expectations. So if you leave with 180 things in your jelly bean, which is your diagnostic imaging or documents jelly bean, don't come back and expect it to be cleared, because I have had that before. It's like, no, 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 no. That's not what provider desktop
You
coverage
leave
is.
without any jelly beans, so you come back without any jelly beans.
Yes. So, all right, Christine, what else you
Also,
got for me?
okay, how do referrals get tracked and loop closed to ensure that the referrals process authorized and patient was notified?
Whole team that does that. So provider puts the referrals in. We have a referrals team. So the referrals team is actually basically responsible for finding out if there's any kind of authorization or anything that this patient is going to need, getting that authorization, setting up that appointment to go, and they're responsible for grabbing and catching the notes or the basically the document from the chest X-ray or the report or whatever, and bringing that back into the system. And we have SLAs. So we basically have time, a certain amount of time that we're saying, hey, referrals folks who are our folks, that you need to do this in this manner and this quickly. We also have the ability to do routine, urgent, and stat. And they know that the time frames between those. And then they also, with having a lot of our referrals people, we have referrals people sitting inside the centers. They can actually, across the desk, so to speak, in addition to sending in a T or a document form, say, hey, look, I scheduled a patient for John Smith to go see the cardiologist. They didn't show up, right? So that closes the loop. And then to that point is that the provider, they're in the center. We can capture those folks.
Okay, we are out of time. I'm putting my email in the chat, and the reason why I'm doing that is I'm already telling Dr. McGee before we've discussed doing this quarterly. Like you and I or some people on your team, maybe our AMDs. So if you have some suggestions of something you want to know more information about with us, just email me that information. But we're looking at doing this quarterly, and we'll let you know. We'll let you know when our next one is. Thank you all for attending. Dr. McGee, do you have anything else you want to add?
No, I really thank you so much for joining. And remember, sometimes I get a little bit lost in that I'm CenterWell, but we're CenterWell and Conviva. So if you go look, and I know you guys are across, and I do these things because I want people to know about us and to know about us across all of our markets we're in. We're in 16 or 18 states, right? And so the more mature clinics that have maybe 20 years of experience are usually Conviva clinics. So there's, like Conviva clinics in Texas and a lot of those in Florida and places. Those are part of the same organization. Just the brand new clinics that have started in the past few years are called CenterWell. So it's kind of one and the same. So, definitely reach out to Chris Ann. She can link you if it happens to be that it's Conviva that is in one of the more so in one of the states that you're in. She can link you to those folks who recruit those clinics as well if you have more desire or interest or any of those sorts of things. And appreciate every one of you. And also really would like to reiterate the thing that Chris Ann said. As we do these, like we're going to do more of these for us for Louisiana, Mississippi, where we do some things like this, but it kind of has the broad approach and for the entirety of CenterWell and Conviva. But things that you would like to hear from us, we would love to, for some people to submit, things they'd like to hear. And we can talk about those on some of these quarterlies and all, and make it maybe a little bit more interactive about things that you guys kind of really want to hear about. But thank you for your time. I know you took time away from your evening, so really appreciate you guys being here.
Thank you.
All right. Take care, guys.
Thanks, Dr. McGee.
All right. Anytime.